Hello, I'm Maria Williams with the Collaborative on Health and the Environment. CHE enjoys bringing you the latest environmental health science through our partnership calls and webinars, news feeds, publications, and social media. I would like to welcome everyone to today's CHE partnership webinar, which is titled County Level Cumulative Environmental Quality Associated with Cancer Incidence. Our moderator today is Ted Shetler, CHE Science Director and also Science Director of the Science and Environmental Health Network. We will leave time following the presentations for a brief Q&A session. You may type in questions through the Q&A feature available on the menu bar at the top of your window at any point during the presentations. After the presentations, our moderator will read questions out for our panelists to respond to. We will get to as many questions as we can during the Q&A period. For those of you who called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. This webinar is scheduled to last for 45 minutes and is being recorded for our call and webinar archive. With that, I'll turn things over to you, Ted.
Thank you very much, Maria, and good morning or good afternoon to all who have joined us. It's a pleasure for me to moderate today's webinar. Many of you will recall that at the Collaborative on Health and the Environment, we frequently talk about the ecological framework or ecological paradigm of health. And what we're referring to is a nested set of relationships in which individuals are progressively nested within families, communities, ecosystems, and societies more broadly. And features of that kind of nested set of relationships include multiple environmental factors, exposures, if you will, that interact at each of those levels, creating the conditions for health or disease in individuals and in entire populations. Today, we're going to hear about a fairly recent study which looks at cumulative environmental exposures at the county level across the United States and looks at those associations with cancer incidence. We're fortunate today to have the primary author of that study with us, Jyotsna Jagai. Jyotsna is an environmental epidemiologist and research assistant professor in the Division of Environmental and Occupational Health Sciences at the University of Illinois in Chicago. Her research focuses on how ambient environment of residents can affect acute and chronic health outcomes. She completed her postdoctoral fellowship with the US EPA, where she worked with a team to develop the Environmental Quality Index on a county level for the entire country. And she will describe that tool today. She continues to collaborate with colleagues at the US EPA to update the index and develop versions for smaller geographic scales. And she would like to expand this work to consider the impact of cumulative environmental exposures on other health outcomes as well. After Jyotsna makes her presentation, we have with us Dr. Richard Clapp, who will provide some comments following Jyotsna's slides. Dick is a professor emeritus of environmental health at the Boston University School of Public Health and adjunct professor at the University of Massachusetts at Lowell. Dick is an epidemiologist with over 40 years of experience in public health practice, research, teaching, and consulting. His MPH is from the Harvard School of Public Health and a Doctor of Science in Epidemiology from Boston University. He served as the founding director of the Massachusetts Cancer Registry from 1980 to 89, and Dick has been a valued CHE partner for a number of years and has contributed on CHE calls in the past. So with that, Jyotsna, I'll turn it over to you. Please go ahead.
Thank you very much, Ted. I just wanted to first of all thank the Collaborative on Health and the Environment for inviting me to conduct this webinar. and also for Maria Williams for organizing and dealing with all of the logistics, and Dr. Shetler for providing moderation. And finally, I am so honored to be giving this webinar with one of my mentors, Dr. Richard Clapp. So with that, I'll get started. This is work on the county level cumulative environmental quality and how it's associated with cancer incidence. As we know, cancer is associated with ambient environmental exposures. There's been a lot of work specifically on arsenic in water and lung and bladder cancer, air pollution and its associations with lung cancer, and pesticides, which are associated with various cancer types. But often environmental epidemiology focuses on single exposures and individual exposure types, such as arsenic or air pollution. But we fail to think about the broader ambient environment and the overall environmental exposures that we're faced with regularly, and how the cumulative environmental exposures are associated with cancer risk is not well understood. So as we know, harmful exposures and benign factors often occur simultaneously. While they might go in parallel, for example, areas that may be low poverty or not as well or ethnically diverse might be faced with higher industrial pollutants, whereas areas that might be higher income or in nicer areas that we think about as nicer areas might have access to things that are more beneficial to your health, such as parks and recreational facilities. But what we need to think about is how cancer risk is related to these multifactorial exposures. And while there is a huge genetic risk with cancer, these environmental factors can exacerbate that genetic risk. So in order to think about how we are faced with accumulative environmental exposures, when we were at the Environmental Protection Agency, we developed this Environmental Quality Index. And the goal was to construct an index for all counties in the US, considering multiple domains that influence both the exposure and health outcomes. We considered 5 environmental domains: air, water, land, the built environment, and the sociodemographic environment. And we considered factors data that represent chemical, natural, and also the built environment overall. So to create the index, we considered several different data sources, the majority of which were or are publicly available. For the air domain, we considered data from the air quality system, the National Air Toxics Assessments. For the built environment domain, we considered data from the Duns and Bradstreet classification system, Tiger data, which is related to roads and roadways, fatality annual reporting, and housing and urban development. For the water domain, we looked at primarily regulatory data sets that the US EPA monitors, the National Contaminant Occurrence Database, Atmospheric Deposition Program data, water use estimates data from the Geological Survey, and drought monitoring data. For the sociodemographic domain, we considered census data and crime report data. And finally, from the land domain, we considered the agricultural census data, national priority list data, and the geochemical survey data. So from these different data sets, we were able to construct several variables to represent each domain. This is just a list of some of the samples of types of variables that were created. So for air pollution, we considered criteria and hazardous air pollutants, particulate matter, sulfide dioxide, lead compounds. For the water domain, we considered various contaminants that were present in waters, drought status, the number of discharge permits in a county, and water withdrawals for various uses. In the land domain, we considered things such as the percentage of land in various crop types, insecticide-treated crops in the county, the number and count of Superfund and brownfield sites, and concentrations in sediment samples of various contaminants. For the sociodemographic domain, we considered things such as median household income, percentage of individuals with less than a high school education, violent crime rate, and property crime. And finally, in the built environment domain, we considered things such as the density of fast food restaurants, the percentage of roadways that are highways as opposed to smaller streets, and density of fatal accidents, and the number and density of public housing units. So from all of these 19 different data sources, we gathered data that represented the time period from 2000 to 2005. And we constructed 5 domain-specific indices to represent each of the individual domains, and we used a principal components analysis to do that. And then once we had each of the individual domain indices, we combined those together to create an overall environmental quality index, again using a PCA. But we recognize that here in the US, that there is a significant difference in urban and rural neighborhoods or areas, and that the drivers of environmental pollution in those areas might be very different. So to address this, we stratified our index construction using 4 strata of urban-rural continuum codes. So we used, the first code represented the metropolitan urbanized areas. Those are your very large cities, densely populated areas. RUCC 2 are the non-metropolitan urbanized areas. Those are things that are suburban, but still very close to your major cities. And then RUCC 3 was less urbanized, and RUCC 4 are thinly populated areas. So in the end, we had quite a complex matrix, but we had air variables, water variables, land, built, sociodemographic variables, and then we created indices for each RUCC strata of urban-rural continuum, as well as one index for overall, all counties. And then all of those were in turn grouped to create the overall EQI by RUCC, as well as for all counties in the US. So this is the end result of that work. This is the overall environmental quality index by urban-rural continuum code for 2000 to 2005. And just to orient you, the darker areas are those counties in the highest percentile, which represent the most polluted or the poorest environmental quality areas. And the lighter shades are those that are in the higher environmental quality areas. So then for this particular analysis, I use data from the SEER program, the Surveillance, Epidemiology, and End Results program, from their state cancer profiles project. And they provide data at the county level of cancer incidence for all states that participate in the program. And I think, as I recall, there are only 2 states that do not participate in the program. And so we gathered county level annual age-adjusted all-site cancer incidence rates for the years 2006 to 2010. And the data are all publicly available for download. And we use that time period from 6 to 10 to be lagged from our exposure data, which represent the period 2000 to 2005. And then again, we had data for 2687 of the 3142 counties in the US. So for the statistical analysis, we assessed relationships between county-level EQI and domain-specific indices and all-site cancer incidence. I'll be presenting results for the all-site cancer incidence. We also considered the 3 most prevalent cancers for males and females, which are lung cancer, colorectal cancer, and breast and prostate cancer. Those results are available, and if we have time, I can go into those. For methods, we used a fixed slope random intercept multi-level linear regression model with state as our random effect and county as a fixed effect. And we considered EQI quintiles just for ease of interpretation. And then again, all analyses were adjusted for county percentage of people who ever smoked. And then those analyses on breast cancer were also adjusted for county level mammography screening rates. The results are reported as an incident rate difference comparing the highest quintile or the worst environmental quality to the lowest quintile, the best environmental quality. And all analyses were again stratified by RUCC. So this figure, I just wanted to get us situated or familiarized with the interpretation and how to read these figures. So first we're considering all counties, and that's this green triangle. And the interpretation is that counties with poor environmental quality demonstrated a higher incidence of cancer cases, on average about 39 more cancers per 100,000 people than counties with high environmental quality over the period of the study. When we looked at males alone, they demonstrated on average 30 more cases per 100,000 people in counties with poor environmental quality compared to those with high environmental quality. And for females, counties with poor environmental quality demonstrated about 33 more cases per 100,000 people than counties with high environmental quality over the study period. So then when we look at all the results here, the first are just what we discussed, but then the next group is RUCC1, and that's the most urbanized areas. And you can see that again for all overall and both males and females, there was a strong association with overall environmental quality. In RUCC2, the association was less clear for males, but still strong for females and overall. RUCC3, all 3 demonstrated strong association again. And in the thinly populated counties, the associations are not significant. And now here we're looking at the domain-specific results. And so we're able to tease apart how the associations are related to the specific domains of air, water, land, built, and the sociodemographic domain. So the first section of results is looking at the overall EQI for all counties and males and females combined. And you can see that there's a trend that while positive, in the thinly populated area, the result is not as strong. For air pollution, all strata of urban-rural continuum demonstrated a high significance and positive associations. In the water domain, the associations were negative or null. And in the land domain, we had positive associations in the 2 most urban strata, but not in the less urban and thinly populated strata. The built and sociodemographic domains both showed strong associations overall, positive associations overall. So we found that all-cause cancer was strongly positively associated with poor environmental quality for both sexes, and RUCC stratified models demonstrated positive associations for males in the majority of strata and in all strata for females. In domain-specific analyses, the strongest positive associations were seen in the air domain across all strata of the urban-rural continuum, and the built and sociodemographic domains also demonstrated positive associations across RUCC. This work is an exploration of county-level associations between environmental quality and cancer incidence, and is the first that we're aware of to look at this. The Environmental Quality Index is the first attempt to combine data on 5 domains to represent overall environmental quality. And environmental quality appears to be differentially distributed across the urban-rural continuum. Associations in the most urbanized areas were strongest for both males and female and across the domain-specific indices. And these results suggest that environmental quality can influence cancer risk and that associations vary by urbanicity. Some of the limitations of this work are around the construction of the EQI. Both spatial and temporal coverage of the constituent variables was sometimes limited. The data that we used for the majority of the domains was regulatory data, and regulatory data are often collected when needed, if there is some reason for concern, or if particularly in areas where a particular contaminant might be of concern. And so often that meant that we didn't have coverage for the entire country and required kriging or some different techniques in order to get data values for all counties in the US. Likewise, because of the fact that the regulatory process does not require, in all domains, does not require continuous monitoring, the temporal coverage was not as regular or frequent as we might have wanted. And this is why we actually had to construct the EQI to represent the entire time period from 2000 to 2005, as opposed to having maybe an annual index. Similarly, there is a potential for urban bias, as again, a lot of the regulatory data are collected in areas where the majority of people might be affected, which suggests that it might be collected in urban areas. So those are some of the limitations with the data that we had. And then thinking specifically about the cancer analysis, we were unable to look at racial differences due to low counts in rural areas, but that is something that I would like to see if there might be data that we could consider. And then another issue was the lag period for the development of cancer. As we know, that cancer has a very long lag period in development, and it varies significantly for different cancer types. And so we were only able to consider about a 5-year lag period, maybe 10, depending on how you wanted to average, because the EQI represents 2000 to 2005, and then we were collecting data for cancer incidence that was 6 to 10. So we had about a 5 to 10 year lag period. However, we are in the process of developing the 2006 to 2010 EQI for the next time period, and some of our preliminary analyses suggest that this rank index doesn't change much between the 2 time periods, and so it might be representative of environmental quality over a longer time period. However, again, some of the cancer lag times cancer development lag times might be over 20 years, and we cannot address that in our exposures. So some of the strengths of the EQI construction is that it is the first attempt to model the multifactorial nature of environmental exposures, and we were able to incorporate variables from multiple different domains, thinking about the very broad context of environmental exposures and considering even the broader context of sociodemographic exposures. And we were able to address some of the differences in urban-rural areas by conducting a stratified analysis and creating the EQI as a stratified exposure. And then some of the strengths in the analysis with the EQI and cancer incidence was that it's a national scale analysis. And as I mentioned, we had a broad environmental context that we considered. So some of the next steps for this work are to construct the next EQI to represent the period from 6 to 10, and then also to construct indices at lower levels of geographic aggregation. And we're considering the census tract because in the US, counties can vary by size significantly and represent a really heterogeneous types of exposures. And so if we are able to get down to a smaller geographic scale, it might allow us to have a finer assessment of environmental exposures. And then as far as work with cancer specifically, we're interested in looking at associations between environmental quality and cancer survival times. And so this work would not have been possible without this great team of those that are working on the EQI, and it gets bigger and bigger day to day. And so these are the names. We have Danelle Lobdell, who spearheads the entire project, Lynn Messer, Kristen Rapazzo, Christine Gray, Shannon Graybach, Achal Patel, Allison Krajewski, Monica Jimenez, and Stephanie DeFlorio Barker. And then the funding for this work, and lastly, some of the GIS specialists who helped us on data abstraction and data kriging for getting county level data. So that's all I had. Thank you very much.
Jyotsna, thank you very much. That's a wonderful presentation. Dick, your comments and reflections.
Sure, thanks. And it's my pleasure to be on this webinar with Jyotsna. We met about 15 years ago, I think, when she was working on her master's at Tufts, and we did a project together where she looked at the emerging information about PFCs, or especially perfluorooctanoic acid, as it was developing. And as you probably all know on this call, that has become a major issue. So Jyotsna was there at the beginning of that whole effort and wrote a case report that was put online. So it's a pleasure to be back in touch. I wanted to make a couple of comments about where this all fits as sort of the historical progression of this kind of work. When I was director, as Ted mentioned, I was director of the State Cancer Registry in Massachusetts in the 1980s. We actually tried to do this kind of work at the state level. We tried to incorporate whatever available information we could get from EPA and the Department of Environmental Quality Engineering, as it used to be called in Massachusetts. We looked at occupational and industrial profiles of the cities and towns in Massachusetts. We took into account racial disparities to the extent that that was represented in the cancer statistics. But I have to say, we didn't get very far. The colleagues at DEQE and I were trying to create what we called a cancer environment registry. And we never did succeed because the data were too sparse, especially at the state, at the city and town level. There was very spotty information about air quality, water quality. The census information was there, but we couldn't put it all together. So we basically put that project aside. And then at the end of the 1980s, there was an analysis that's quite similar to what Jyotsna and her colleagues have done. It was a analysis of cancer mortality by county in the US in relation to hazardous waste exposures or hazardous waste sites. And this was led by a researcher named Jack Griffith at the EPA at the time. And it did show a similar kind of result. It was just looking at hazardous waste as the exposure, and it was age-adjusted cancer incidence or cancer mortality rates. And it tended to show that if you lived in a county that had a hazardous waste site or more, one or more, you were more likely to have died of cancer and of some specific types of cancer. So that was pushing this a little bit further and was using national data that was available in the late 1980s. Jyotsna mentioned in one of her future efforts, she wants to look at what might be called survival by EQI. A similar effort was done in the UK looking at cancer survival by what they call deprivation index. And so there's a whole actually school of epidemiology, I would call it social epidemiology, that's well developed in the UK. And they were able to show that, again, using what they call a deprivation index, which is mostly related to sociodemographic variables, there was a sharp gradient, and the more deprived you were in terms of where you lived, the more likely you were to either get cancer or die of cancer. So that's beginning to put together the larger composite picture that Jyotsna has now compiled. And I commend her for, I realized what an enormous effort this was. Simply compiling the data from which the principal components analysis could be done in order to generate the environmental quality index was an enormous and courageous piece of work itself. And then to link it to cancer incidence information, as I say, it's a heroic effort. And I was very excited to see this when it came out a couple of months ago, and I commended it to Che for this topic as a topic for this seminar. I want to say a couple more things about what sometimes is called the ecologic fallacy in epidemiology. This is a term that is in textbooks, and it basically says that if you look at the level of, say, a county or even grouped data that doesn't reflect individuals themselves, you're looking at an ecological analysis. Ted actually mentioned this in his introduction as something that we in the Che network think is a good thing. We want to think about the multiple embedded levels at which exposures and stresses occur that increase disease risk. But in epidemiology, it's often looked at as a detriment, as something that means you don't really know what's going on at the individual level. And so I think we need to keep that in mind, that there will be, and in fact, I read a critique of Jyotsna's work by an epidemiologist named Jeffrey Cabot, who was at Mount Sinai Medical School now in New York City. And this was sort of the thrust of his complaint, is that, well, you don't really know what was going on with the individuals. And also you don't, even if you look at smoking, ever smoking by county, you don't really know how long people smoked or how intense their smoking histories were. Well, that's all true. And yet that, I think, is missing the forest for the trees. It's a reductionist attitude about, if you don't know even kind of at the individual or I suppose ultimately molecular level what went on with those individual patients, you don't really know what the cause and effect relationship is. Again, I would say that might be true. You don't know what caused an individual's disease to either be initiated or progress, but it's missing the forest for the trees. What Jyotsna has done is, I think, taken us to looking at the forest, or looking, if you might use the analogy of looking at the country from 30,000 feet to see what kind of patterns you can observe there. And I consider that a major step forward. And it does, as Jyotsna and I think an accompanying editorial that also came out in the same issue of Cancer, the journal called Cancer, said, this may lead us to look for, high-risk areas, high-risk populations, or new ways to approach cancer prevention that haven't been obvious by just looking at the trees. So I might say a little bit more about the ecologic fallacy. There are a number of people who've looked into the details of this and how bias might occur when you're looking at ecological data. There may be somebody who's already on this webinar who can weigh in on that. But again, I would say we need to keep in mind that there are at least two schools of thought about this. One is that ecological conceptualization is good, and we need to do more of that at the 30,000 foot or whole forest level. And there may be some limitations that allow us or prevent us from drawing individual causation or even specific disease causation conclusions from this kind of data. I think that what Jyotsna has done has been a great step forward. I look forward to her further work if she were able to go to census tract or census groups as smaller units than counties. That will be a step forward. And I guess I would say one last thing, which is the cancer incidence data that she assembled. It's actually from a large database that the National Cancer Institute keeps track of. That also it's not complete. There are a couple of states that don't contribute to the NCI summary. That's the online link in Jyotsna's paper. But it is a large proportion of the population. But even that is where people live when they were diagnosed. So, and that means that sort of by definition, you don't know residential history. You don't know that the person who was diagnosed with, say, lung cancer in, say, Allegheny County in Pennsylvania had lived there their entire life, or even some significant portion of their life before they were diagnosed. That kind of detail is not in the cancer registry. And you can only get that kind of detail, residential and typically occupational information, by going and interviewing the patient or the next of kin. So that's maybe another limitation of even the cancer incidence data that's used in an analysis like this. Having said all that, I would still say I commend Jyotsna and her colleagues for having pushed the envelope here and given us lots to chew on. Those are my comments, Ted. Maybe we can.
Thank you very much, Dick. Very, very helpful. We do have a few minutes for question and answers, and I have the Q&A box open. And Jyotsna, what I'll do is just read off occasional questions here and appreciate your answers. The first one is, what is this? Was radon considered within the land variable since it is a known lung cancer risk?
Yes, we do have the radon zones in the land variable.
Right.
In the land, sorry.
Thank you. There are two questions that have to do with the statistical analysis, and I don't think this is a good time to get too deep into the weeds, but one is, was principal component analysis chosen after trying different approaches? And then the other one comes from a toxicologist who wonders if we could get more information about the method or more information later. So maybe you can address those.
Yeah, so we really started with principal components analysis. One of our colleagues who's spearhead the analysis portion of developing the EQI has considered other types prior to in her previous work, and had come to the conclusion that PCA was the most useful for this type of an index development. And so she suggested that we use that. So after having worked with the principal components analysis, there was some preliminary investigation into a couple of other methods. However, they did not come out significantly differently and were more difficult to explain. And so we decided to stay with the principal components analysis method. To address the question of additional work, yes, I believe on the CHE website, Maria has linked the paper that this work comes from, the cancer incidence paper, but in that paper, there are 2 or 3 references to papers that lead to the development of, or discuss the development of the EQI, one specifically on data sources and databases that were used, and the other talking about the PCA, the loadings, and the final product. So hopefully those are accessible. And if they aren't, please email me and I'm happy to send you data, or sorry, not data, papers. And even the link to the data. In fact, the EQI is publicly available, so I can provide that link as well if that's something that anyone is interested in. And I think Maria posted that link, if I am not mistaken.
Yeah, thank you very much for that. Catherine Thompson asks, she notes that air EQI had the strongest association. Could you tell us if that was mostly due to lung cancer, or if colorectal, breast, and or prostate are also positively associated with air?
Yeah, so we did see strong associations with the air domain when we looked at site-specific cancers. And so lung cancer, breast, and prostate all three also demonstrated strong associations with the air domain. Colorectal was not as strong. And if I remember correctly, the associations in colorectal varied by RUCC, by urban-rural strata for the air domain, whereas they were pretty positive and strongly positive for the other three cancer types.
Thank you. Alexander Scranton raises a question about the water pollution data, and I had a similar thought when I was looking at your paper. It looked to me as if the urban areas and the next to urban areas actually had a protective association with water quality that disappeared in the rural areas. Do you have any speculations about why that might be true?
The water quality data is probably one of the most challenging data, or most challenging domains for data that we had. A lot of the data that we ended up being able to use for the water domain were proxies of water quality, and not really strong measures of direct water quality. So for example, we use things like discharge permits. And so it doesn't necessarily tell us if there was a discharge or how significant of a discharge or what type of a discharge, but rather that there is potential for industrial or chemical discharges in that particular county. So, so there was a bit of an issue in the sense that it's probably not the strongest domain as far as the data quality going into the EQI. And a lot of the data that we've been able to use are not direct drinking water or recreational water data, but rather data from the contaminant data, for example, is streams and rivers, which don't necessarily reflect an individual level exposure or exposure that might be associated with a health outcome. So I don't know exactly what is happening in the water domain, but I do think one of our challenges is the data quality going into the water domain. And we're considering a couple of new databases for the 26 to 10 EQI development, which we're hoping might allow us to look at some more specific drinking water quality data.
Thank you. I think we have time for one or two more. One question is, the person is surprised to see that RUCC3 is higher than RUCC1 in the air domain. Would assume air quality being worse in urban areas leading to higher incidence of cancer. Can you speak to why you saw the RUCC3 air domain highest?
Yeah, I think there might be a couple of things driving that. I think one might be that RUCC3, while might not have the highest air pollution, is still an area that probably has a lot of heavy traffic, truck traffic and highways. So I don't think it, while probably doesn't have, you know, the urban air pollution, but still does have a significant amount of air pollution, I would think. So that's one issue. I think the other thing is that we are looking at incidence rates. And so I think when you think about the rate of cancers in the urban areas, we have a larger denominator. And so the rates might not be as high as when you're thinking about individual cases of cancer.
Uh-huh.
Well, plus standard deviation. There's a line above and below the triangles that indicates, you know, the possible range of these results. And so I think those two overlap.
Oh, okay. Yeah, I'm not looking at the results themselves. So. Perfect.
Well, thank you very much. I think that's all we have time for. We're at the end of the webinar. I just really want to thank Jyotsna and Dick for joining us. And I also just want to thank Jyotsna and her team for this really powerful work that I think is really sort of blazing a new trail that I hope others will continue to follow. And I look forward to your additional work, Jyotsna. Maria, I'll turn it back to you for closing us out.
Thank you very much, Ted. We are approaching the end of our webinar today. A video recording of this webinar will be available on the CHE website soon. Tomorrow you will receive an email containing a link to the video. CHE's next partnership call, hosted by the CHE Alaska Partnership, will take place during the last week of July. Details will be available on CHE's website as they become available at healthandenvironment.org. If you are new to CHE and would like to learn more about becoming a CHE partner, please visit the Join Now page of the CHE website. Additionally, if you appreciate these CHE partnership webinars, bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I want to thank our speakers once more for taking the time to present today, and Ted for his excellent moderation. Thank you very much for joining us, and have a great day.